Okay, welcome to this very first ESVONC podcast. I'm very happy to have Jerome Benoit as my first guest. Many of you will know Jerome very well. For those who don't, I'm very happy to share Jerome's quite impressive CV. Jerome graduated from the Veterinary School of Lyon in 2005. He then completed a radiation oncology residency in North Carolina. In 2009, and then in 2010 he became diplomate of the American College of Veterinary Radiology and Radiation Oncology. And in 2015 he became diplomate of the European College of Veterinary Diagnostic Imaging. Jerome worked in the UK for a few years, and currently he is the clinical director and head of radiation oncology at OncoVet in the north of France. And he also does quite some consultancy work for other European institutions. Besides that, Jerome does a lot of voluntary work, a lot for ESVONC. We'll talk about that later. And also he's member of several committees at the ECVDI, and also member of the Veterinary Radiation and Radio Protection Task Force from since 2015, actually. Jerome, welcome.
Hi, Tom.
To start off, Jerome, excuse me?
Sorry?
Can you hear me well?
Yeah, very well.
Okay. To start off, Jerome, I have a bottle of French wine next to me. It's actually from the Rhone region, so it brings you back to me back to where you studied in Lyon. So cheers to you.
Cheers, Tom. I've got some Belgian beer.
Okay.
Cheers to you.
Yeah, we started this podcast and give the floor to people to have a discussion we actually don't have or haven't had for quite a long time, since congresses couldn't go on. We had to cancel ESVONC 2 last year. This year it'll be a virtual congress. I think we can say that we miss each other. But on the other hand, if Corona wouldn't have appeared, then maybe we wouldn't have these online meetings, or maybe in a few years' time. So maybe to start off with, Jerome, how does your current work actually look like? You work in the north of France at OncoVet. What does an average week actually look like for you?
Well, it's busy. It's been very busy during COVID. I think people have really focused on their family and pets. And so we haven't seen a drop at all in our caseload, which is nice, but can be a bit exhausting, obviously, considering all the restrictions and the way we welcome people and so on. So it's always a bit more complicated, but yeah, we've been very busy. So I'm head of radiation oncology. I have a resident with me, which helps to be 2 in the team, plus technicians, to deal with the caseload we have. And I'm the clinical director as well of OncoVet. I've got a bit of administrative work on the side and to deal with the team and manage the team. It's fun. As far as work, clinical work, I mean. So we see consultations every day. Our clients are coming from quite far away. So I think that's quite specific for radiation oncology, that we do attract clients from pretty much all of France, Spain, east of France, Luxembourg, Belgium, of course, because we are just 15 minutes away from Belgium. Some clients from the Netherlands as well sometimes. So it's quite international. It's quite nice to see different people, different background, different type of clients coming to us for treatments. So these pets usually spend a few weeks with us. So it's also quite different, I think, compared to other disciplines. Usually radiation protocols go for 2 weeks, 3-4 weeks. It's quite surprising to see how many clients actually are not willing to leave their animal in hospital, and they rent an Airbnb or hotel next to us, or some people just travel hours every day to bring their pets. That's pretty much it.
So like with Corona, were you allowed to see clients in your clinic, or did you do it outside?
We've talked about this, but we kept one client, only one person per consultation. So that's the only thing we've changed. And of course, all the gears, masks, and so on. Yeah. I've since COVID, which is quite nice, I've started doing a lot more telephone consultation. And I think that works very well for my discipline, because clients coming from so far, sometimes a bit silly to have them coming just for consult, just for chat. And so, and that works very well. It really helps to bring new cases, people who probably not have traveled to us if they didn't have that first contact with us. So they pay a normal consultation fee, and we discuss about the protocols and side effects and so on. They have an idea of costs and so on. So when they come in, they know pretty much what's going to happen. They've chosen their protocol, they've booked their hotels and so on. So it makes things a lot easier for them.
Yeah. So it's actually some sort of a digital transformation already.
Yeah. No way. Yeah.
I often wondered, you must get tons of emails. I sometimes email you, but I will not be the only one. There will be a lot of vets, a lot of owners, a lot of clinics from around the world. I know you do quite some treatment planning also for other radiation facilities. Sometimes I think, well, how does he manage?
It's hard. It's hard, and we need to learn to say no a little bit, I think. We're getting slightly overwhelmed by emails, inquiries. We welcome inquiries from vets. I think this is something we continue doing, obviously. Now, inquiries directly from clients is something we can't continue to answer, because there's too many. Usually you don't have enough information about the pet, about the medical case. So it's a bit of a waste of time, really. So, but we do encourage them to talk to their vets, maybe ask their vets talk to us. To try to drive them a bit more eventually towards us for treatment. But we get tons of inquiries, and it's becoming really a problem, because it does affect the time we have available for this, and we cannot prioritize inquiries over cases we actually have in-house for treatment. So I don't know what solution you have, but it's something we constantly think about, try to optimize this free service in a way that we've been doing for years.
I mean, we see the same, and sometimes I think, can we standardize some things? I can imagine that the story of a nasal tumor treatment, adenocarcinoma, would be pretty much a standard talk in some sense. I don't know if that is.
Yeah, but at the same time, I always say I spend half of my consultation talking about logistics and prices and what they want. And I truly believe that our definition of success for treatment is really to best define what clients want, because you can't take them in a path where maybe the treatment is too intensive, there will be side effects they can't deal with. So it's very important to really define outside the theory and the standard protocols, to really define with them what would be the protocol they want for their pet and for themselves. And that's why it's so difficult in inquiries. Some vets just ask, "Oh, I've got this, whatever, fibrosarcoma in a cat. What do you do?" well, I don't know what I do, because it's for the client to tell me pretty much what we do most of the time. And I really try to have a client-based decision process. It's not just it's the patient, of course, but it's really much about the pet owner.
Sometimes I had a feeling that more than half of our work is communication. And the veterinary medicine part is maybe less than half of it sometimes.
Yeah. And you have to adapt to the person in front of you. Some people, I don't know, because they don't get it, they don't sometimes have a very poor understanding of the situation, or you can't necessarily offer everything and discuss every possible option with every client. So yeah, it's a lot of psychology. And I'm talking about radiation as an example, because it involves weeks of treatment and quite a high budget for this kind of treatment. It's so important that they're on board from the beginning. Otherwise, you create frustrations and anxiety when side effects start, or if there's any complications. So you need to be very clear from the start about what the process is going to be for them. Yeah.
Do you also do a lot of research also, or
in Oncovet? Yeah. So it's a referral-only clinic. It was founded about 20 years ago with a very high focus on oncology. And so we've got connections with different research facilities, pharmaceutical companies. There was a spin-off company called Oncovet Clinical Research that was created of Oncovet a few years ago, and now separated. But that brings clinical trials into the practice. With COVID, there's been a lot less because of obvious reasons. So a lot of new trials that were supposed to start last year didn't really start. So there's a bit of a backlog of them. But yeah, that's something we like doing, because it does offer sometimes the opportunity for some clients who would not be able to afford anything, or not much, to get into a trial where pretty much everything is covered. Diagnostics, staging, treatment, or the follow-up visits. So it's quite nice in this way. Yeah.
And does it also involve quite some research in radiotherapy, or do you look at as a whole gamma of research you're involved in? Personally?
Personally, well, some of these clinical trials involve radiotherapy, usually as a combination with some chemo or immunotherapies being investigated. Otherwise, internally, it's pretty much just clinical vet research, sort of little retrospective or prospective studies we try doing. Yeah.
Okay. Well, nice of you to share with us how actually your work is. It's these kind of things that at a Congress we talk to about when we're in a cafe at the end of the day. Going over to ESVONC, in a few weeks we will have that first virtual ESVONC Congress. We had to skip the one last year because of obvious reasons. And we had hoped last year to have it in Italy now, but that seemed too early.
Every month, so because we were one of the first one to be cancelled, we didn't know what was going on. So we were like, oh yeah, maybe let's postpone by a month or 2 months. But by April, we just realized, it was just obvious that nothing would happen. And we decided not to postpone, but just to cancel.
Especially because Italy had quite a hard time at that moment. So this year it's a virtual Congress. Can you explain how it will work? What will be the mode of action?
Well, so you get connections to 2 rooms. So what we decided is to have the Congress over 2 days only, because nobody would travel these times, and to fit with your own sort of clinical work, not to have too much time off work, I guess, and thinking that there would be a replay of every lecture for months afterwards. It was sensible to have the Congress just over 2 days with 2 separate rooms. So you'll be able to access either rooms, depending on what lecture you want to attend on the day, if you want to attend them live. But then all lectures have been recorded for safety reasons. So it's too scary to have any technical issues during the Congress. So all keynote lectures, resident workshop, all abstracts, everything has been recorded. However, the speakers will be available live for Q&A sessions at the end of the session, which is nice. So anyone will be able to chat and ask questions live to still get this sort of live interaction, like a real Congress. Yeah.
And also the posters, they have some sort of a 2-minute presentation or so?
Yeah, so that was the idea, to try to recreate what should be a poster presentation. We know it's not just a poster on a wall, but ideally it's someone to explain, their work and what they've done. So we thought it would be nice for them to have a little short 1-slide presentation, just and this is a bit outside the program, but the posters will be available on our website, on the Congress website, with access for the Congress attendance.
Yeah. So when ESVONC Congress consists out of many abstracts, so the abstracts will be presented. There will also be, because if I remember well, these are abstracts from 2020 and from this submission. Right.
So last year we had everything was ready to start pretty much. So we had all these abstracts that had been accepted. And so we gave them the possibility to maintain the abstracts for this year. So not everybody decided to do so, but many of them did. And then we arranged at the time with VCS also to welcome European abstracts into VCS last year. So VCS agreed last year to create this international session where every ESVONC abstract willing to go to VCS could be sort of fast-tracked into VCS, which was very nice for them to do. Yeah. And so this year, we sort of reopened again the abstract submission to get a bit more. And we got quite a few. And so we've got now pretty much like every year about 25 oral abstracts, and about the same in terms of posters.
That's nice number. There's also this year the elections. They would have been done last year. So quite some people from the board will change. Some will stay, and like you are running for presidency, and since you're the only candidate, the chances are big that you will be the new ESVONC president. What are your ideas? What are your plans for the future for ESVONC?
Well, I'd say first I've been in the EC for a few years, and I see how it works. I think I've got a good understanding of ESVONC as a society and within the EC. And I'm very honored that all EC members staying or willing to stay in the committee are supporting me strongly for this position. I feel that I don't feel there's any politics, in ESVONC. It's a nice society. It's sort of big family. We're all here to help and to make ESVONC progress, to get better and better. And so I don't see it as disruption compared to previous years. It's just a continuation of what we've been doing for so many years. Now, what I'd like to push, I think maybe, and that's something we've been discussing for years, is to find a way for ESVONC to evolve into a society that's not just active around Congress organization, but a society that gets more sort of live all year round with different events and activities. It's a bit of a challenge because it takes volunteers to come and help and have initiatives. But yeah, it's something we can try to push a bit more. We can also enhance our international relationship with other societies. There's a lot of discussion at the moment. It's been on for about a year about the World Congress. So we're meeting with VCS and the other societies quite regularly to discuss how do we want this World Congress to evolve, because nobody's really sure of its value or its purpose. There's probably a need to find a new format. So these are quite interesting conversations we have at the moment. And there's a survey actually going on at the moment. So I sent a link, I think it's on LinkedIn, Facebook. There will be emails again for anyone to, if you could, answer this survey, that'd be interesting to see what ESVONC members want for this World Congress. We'd like to work more around research and how to see how ESVONC can get involved in not organizing research, but maybe having a view of the ongoing research within Europe and try to promote research in different institutions. We're thinking of creating a research grant for residents or PhDs and so on. So all these discussions are ongoing.
Yeah, that's already quite a lot.
It's a lot.
Yeah. Like you said,
there's also a need to look at our constitution. And with COVID, it's quite, so this constitution is something that's available on our website. Nobody really reads it. ESVONC works and it's great. But if you look at it, there's a lot of little things that could be changed and adapted to our new world. Just talking about the AGM, for example, in the Congress, nothing in our constitution makes it ready to have a remote AGM, in case we can't meet. And that's why last year we were not ready to do any of this. Yeah, so lots of little projects. Yeah. It takes time.
Yeah, going on that last thing, do you think we have a role to play within that digital transformation that we already talked about, that you talked about, that you witness yourself in clinic of our profession? Because like you said, oncology is very often a communication thing at the start. Yeah, but we will not be able to give chemo online or do a surgery or RT on, but that communication thing, the European Federation has a few weeks ago presented some sort of a document, working document about that. Yeah, you think we have
quite complex because I think it depends very much on each country policies. In France, it's quite restrictive in what you can actually do in terms of telemedicine or teleconsultation directly to pet owners. Now, giving advice to other vets instead of being a free inquiry, maybe to push a bit more towards telemedicine between professionals could be a way also to make things evolve a bit. Yeah.
Yeah. Jerome, we've shared flights very often when we were in the ESVONC board or hours in airports and so on. So we had some nice discussions in the past, and there was one I remember you had some ideas on ethics in veterinary medicine. And I strongly remember some of them. About how we as a profession move on, things we do, things we don't do, some restricted by cost and so on. We've moved on for many years now. What's your idea about it?
It hasn't changed, and it's still a bit of a struggle sometimes. So clearly our profession evolves, being more and more specialized, and even more in my discipline, where the technology, the equipment is so costly. If you always want the best CT scan or the best linear accelerator, obviously the cost of treatment just increases dramatically. And the more we get specialized, the more probably we let down a lot of pet owners with their pets. It's to me, it's striking. You know, every country is a bit different, obviously, and in some countries where pet insurance are more developed, it's also led to, I think, increase in fees, in veterinary fees. And when I hear stories like in the UK, you know, if a client has, I don't know, 5,000, 6,000 euros and can only afford a palliative treatment for a pet with cancer, I think that's just ridiculous. And there's so many clients, there's so many people are motivated to do and find treatment. So we've got a role to play to find the best way to treat our patients and our clients, and to let as few as possible down when they come to your door. Well, if they don't come to your practice, obviously you can't treat them. But for the ones who have the motivation to come to your practice, push the door, have a consultation, we need to find a way to be able to offer them some sort of treatment. And I think in oncology specifically, there's so many ways to be creative because we don't know anything. And if we only base our practice on the literature, we don't go very far. And so it's the same with chemo, it's the same for radiation. You know, we've got this ability to adapt our protocols and think a bit outside the box to try to fit the objectives of the client and what they can afford and what they can do in terms of logistics. So we have something for them, not just steroids and whatever.
Yeah.
But yeah, so I think this increased technology and all this, it serves our scientific side, but it doesn't necessarily serve our clients all the time. And that's a struggle I think we have to play with. And in Europe, I think maybe that's the great thing about ESVONC and our community. It's quite diverse. We've got general practitioners, we've got specialists, we've got different backgrounds, different training. So I'm sure there's a way to organize oncology and treatment options for our patients, you know, different ways.
Do you think that ethical thing is mainly or only a cost thing, or do you also think that it's let's say a moral thing? Talking about diagnostics or even staging. Sometimes you wonder, well, does doing the diagnosis really change, or doing the staging really change the way I would treat it? And do we then satisfy, like you said, our medical need in our minds and not the pet?
Yeah, it's at every step of the pathway, from diagnostics to treatment and follow-up, we can adapt what we do to best fit what the client can do.
Yeah.
So, but it's a discussion you need to have with the client. You can't just tell them, oh, you need a CT because that's gold standard for staging. If it has to be reduced to just X-rays, fine. And if it's a low-grade mast cell tumor or low-grade soft tissue sarcoma, you know you've got very little chance to find anything anyway on your staging. So that's completely fine. And follow-up, you know, when you see some clients, sometimes they, or standards, let's say, you know, to push for maybe a CT scan every 3 months or every 6 months. Yeah, I don't know. It's not necessary, probably. And there's other ways to do it. But it's a shame to leave people on the side just because of concerns like this. As you said, you know, nasal tumor, we know it's probably radiation treatment. We know we pretty much treat all nasal tumors pretty much the same way. And so if it's an advanced disease and the clients are not so keen to get a biopsy, or maybe the first biopsy was non-diagnostic, there's certainly cases where I don't need a new biopsy for every case, just to feed my need to know exactly what I'm treating. If they can, of course, it's better. If they can't, and they know, it's a discussion with them, then I think it's completely fine, of course. Yeah.
Yeah,
and I'm really pushing, I think, because we're seeing so many cases, and we can't, and in my case, clients coming from so far away, I do not expect them to come back for follow-up. So I'm very happy to have the follow-up being done more locally at their vets or another referral center close to them. That's completely fine. Yeah, I think locally the general vets can do a lot. Our expertise comes when the treatment has to be decided, a protocol has to be designed, but then a lot of the follow-up, sometimes part of the treatment can also be done locally. Some easy surgeries can be done locally. So sometimes it's a way to save money in a way and try to organize the whole treatment as a team between us and general practitioners.
But that again will take much of your time to do that communication.
Yeah, but it's necessary.
Yeah.
I
know for a fact that you do an amazing job on that and being available all that time. So
you can't, and maybe again it's very specific to my specialty, but it's hard to. We cannot just be a technician. Get a case for radiation means nothing if we can't interact with the surgeon. If we can't have a discussion with the one who did the imaging or the neurologist, or what's the point? And that would not be fun at all for me anymore. Just be a technician and irradiate stuff. That's not the point at all. So this discussion is so much needed. I think that's part of the service I'm very happy to offer. And the bond we create between these practices and these clinicians I tend to work with, it's amazing. To me, it takes more, this effort is worthwhile because if I get you, for example, to think about radiation oncology, then it becomes more of a habit to think about it and potentially send cases to us. I will not necessarily make the same effort with a GP, sort of single vet practice who might see an oncology case every 3 years because they don't need to, or they don't want to know usually about radiation oncology. They're very happy to refer the case and don't know much about, what we're doing. But the communication between us and larger centers doing the diagnostic surgeries and so on is so important. I think that's what makes our referral strong. Yeah.
Well, nice. I think we've had a lot of food for thought here these last 45 minutes. Jerome, I really
minutes already.
Yeah, I think so. Jerome, I really want to thank you for this nice conversation.
Thank you, Tom. Thanks for this initiative. I think it's amazing to have this new for ESVONC as well.
We will keep on doing
this. Looking forward to the next one.
So you know what they always say at the end of a podcast: if you like it, you have to subscribe, put the thumbs up, and or share and follow and whatever. So we'll see what happens. Jerome, thank you very much.
Thanks a lot, Tom.
And,
see you soon.
See you soon. Bye bye.
Take care. Bye bye.